النهارده الكلينيكال راوند عن المالتيبل بريجنسي مع مجموعة من الحالات المصاحبة. دي صورة مجرد بس افتتاح للموضوع. ان ده توين بريجنسي. المالتيبل بريجنسي ممكن يبقى توين او تريبلت او كوادريبلتس او اكتر، لكن هيبقى حديثنا منصب النهارده على التوين بريجنسي. احنا محتاجين في الكلينيكال راوند ده 3 نقط. The first point is to diagnose the case. Second point to study some cases, and then to go to a scheme for a focused history for a twin pregnancy. As you know, to diagnose, we need to take number one the history. From the history, we have to search for risk factors for multiple pregnancy. ايه الحاجات اللي موجودة عند الحالة وانا بسألها اللي اتوقع ان ممكن تسبب لها او تكون احد الاشياء اللي لها علاقة بحدوث المالتيبل بريجنسي. اول حاجة الريس. المالتيبل بريجنسي ريشيال في بعض الريسز وخاصة في الافريكان او الساوث امريكان. فاميليال انسيدنس برضو وارد جدا وخاصة ناحية المذر. المالتي فاريتي برضو. advanced age of the mother. Previous affection. If the woman has a previous case of twin pregnancy فده ريسك فاكتور عالي جدا. نبدأ بقى نركز في الأشياء المهمة جدا. ovulation drugs أو ovulatory drugs. كل الاوفيوليشن دراجز سواء الاورال او الانجكشن، وده منتشر جدا حاليا عشان موضوع الانفيرتيليتي. الحالات دي بيكون معاها سوبر اوفيوليشن او مالتي اوفيوليشن، ودي غالبا بيكون معاها مالتيبل بريجنسي والتوينز واحد منهم. الاكثر واكثر من استعمال الدراجز حالات الاي ار تي او الاسيستد ريبرودكتيف تكنيكس كلها، زي الاسم المشهور بتاعنا الاكسي، او نقول الاسم الدارج اطفال الانابيب والحقن المجهري. الحالات دي كلها بتبقى انتندد ان يتم حقن اكثر من جنين، 2 أو 3. طبعا كان زمان في اكثر من كده، دلوقتي 2 أو 3 بيتحقنوا داخل الرحم، وبالتالي so this is potential or iatrogenic condition where multiple pregnancy can occur. After exploration of these factors, if we ask the case about these points, we can find, or sometimes you cannot find any factor or any risk factor in the history. So it is not a must to find one of them. Second point in the history. As you know, history, 2 components. The first component we finished, the risk factor. The second part is the symptoms. There are exaggerated symptoms in case of twins. Symptoms of what? Symptoms of normal pregnancy. First of all, emesis, discomfort, and discharge. Most of or all of the pregnancies are accompanied with nausea and vomiting in the first trimester, some discomfort, some vaginal discharge. But in this condition, there is exaggeration. Second point, the fatigue, dyspnea, also can be found in normal pregnancy, while anemia, excessive weight gain, edema are found in abnormal pregnancies. One of these conditions where anemia, excessive weight gain, and edema, twin pregnancy or multiple pregnancy. You can see these 2 photos, and as you see the link of the source of these photos, very impressive. The excessive vomiting. The problem here that this excessive vomiting or hyperemesis gravidarum is not only in the first trimester. It persists by the name or by the definition of hyperemesis gravidarum. It persists for a while after first or even second trimester. Here is the overdistended abdomen with excessive exhaustion of the mother. With look at the facial expression. Also from the symptoms, you can find that there is excessive vomiting or hyperemesis, excessive fatigue, excessive dyspnea. The woman can complain from pallor, or you can find pallor later on in the examination. The woman can also say that excessive weight gain, edema of the lower limbs, edema of the abdomen, as you will see later on. Second point is the abdominal examination. The abdominal examination, 5 points or 5 items have to be seen in abdominal examination. Over distended abdomen. The pregnancy lead to abdominal distension in the longitudinal diameter more than the transverse diameter. While in the twins or multiple pregnancy, either abnormal contour, as you see here, or the abdominal girth, which is a transverse abdominal diameter, is usually more than 100 cc, 100 centimeters. So this is very important point, the abdominal girth. Second point is the symphysiofundal height, which is higher than expected. So in the longitudinal plane, fundal height is more than expected, and in the transverse, the girth also is very high. We can see another sign, abdominal wall edema. Abdominal wall edema can be present in some cases of pregnancy, yes. It can be present in hypertension, yes. It can be present in polyhydramnios, yes. Also, it can be present in over-distended abdomen due to any reason, yes. One of these conditions is multiple pregnancy or twins. As you see in this in these photos, here is the over-distended abdomen. Look at the transverse diameter, and here is, if we see this abdomen over distended also, the edema here is apparent even with the appearance of Boudrange. Again, in the examination of the abdomen, we need to look for the following. We can see by our eyes during inspection excessive fetal movement. Also, we can see many fetal parts are moving here and here and there. By palpation, we can palpate 3 pools. It is diagnostic. Usually in single-tone pregnancy, we palpate 2 pools, head and breech. Here we can palpate, if we palpate 3 pools, it is diagnostic. By auscultation, 2 fetal heart sounds are present. If we auscultate 2 fetal heart sounds at 2 different areas with a difference of 10 beats per minute, also it is diagnostic. The same issue can be during auscultation if there is gallopresm. Usually this happens when the 2 heart sounds are taken together, so there will be galloping. So these are the findings in abdominal examination. We can make some investigations, but it is not for diagnosis, it is for confirmation, it is for assuring. Sometimes we can diagnose also later on. But primarily, we need to look on the history for risk factors, history for symptoms, examination, general and local. For the local examination, we have to see the abdomen, and we have to search for some abdominal signs of multiple pregnancy. For the investigations, number 1, there is excessive concentration of human chorionic gonadotropin. If we make beta-HCG test in blood, we can observe that higher level than expected for the duration of amenorrhea, and this will take us into the differential diagnosis with vesicular pregnancy, with vesicular mole or hydatidiform mole or molar pregnancy. Second point, if we do non-stress test or CTG, we can find more than 1 trace. 2 traces, 2 heartbeats, 2 heart waves can be traced. Ultrasound is very essential and is very important. Early ultrasound using transvaginal ultrasound is very important to diagnose the issue of chorionicity and amnionicity, and usually this is done in the first trimester. Ultrasound later on is very essential also to diagnose if there is IVGR, intratracheal disc, if there is problem in the amniotic fluid, if there is problem in the placenta, and also to ensure the different presentation. The last and important investigation is a Doppler study. Doppler study is very important, whether for the twin itself, for IVGR, and also for follow-up of some conditions like twin transfusion syndrome. If we look at these photos, Again, in the right side, the black and white and the colored 3D picture. This also look at this white part, and look at this white part, and look at this very thick white part in between these two black shadows here. So this is a placenta, and this is a placenta, and this is the very thick area between the two fetuses or feti. So 1 and 2, so twin double placentae, which are near to each other with this projection, which is delta-like or triangular-like or lambda-like, we will describe later on. So there are two placentae near each other, fusing together. While here, if we look, we can see two gestational sacs, definite. There is one embryo complete, one embryo here, part of one embryo, yolk sac, one placenta, the other placenta. So these are two pictures or two photos of dichorionic twins. Another, if you can see here, this is the same like previous, and this is the fused one. Look here, this is complete separation between the right and left, or as regards my screen, right and left here. So one fetus and second fetus, amniotic fluid, and this is the separation between them. Look at the basal part of separation. If you find the spear-like or this inverted Y shaped or what's called lambda sign, if you find this, this means that the double placentae, 1 and 2, and this is very thick area of the chorion in between the two. So this is also dichorionic. If you look here, again this is dichorionic with definite spear-like. If you look here, we can find on the other hand one fetus, the second fetus, amniotic fluid. We cannot find this spear-like. There is just a membrane, very thin membrane between both these two fetuses. So two amniotic cavities, diamniotic with single placenta. In the single placenta, usually we find this thin membrane. Another case of thin membrane, you can see this is amniotic cavity and this another amniotic cavity, and this is one fetus and the second fetus. If you can go with my trace here, this is the membrane, which is very thin. Look at the junction between this membrane and the placenta. It is similar to inverted T shape. While here, if you look at the junction between this membrane and the placenta, it is inverted Y shape. This inverted Y or lambda shape, so these are two fused placentae, dichorionic. Here is one placenta, it is monochorionic. So it is dichorionic, diamniotic, it is monochorionic, diamniotic. So on the right side here, dichorionic, diamniotic. In the left side here, monochorionic, diamniotic. So by this rapid summary of the history, examination, and some of the investigation, we can conclude that twin pregnancy can be expected from the risk factors. It can be expected after taking history of some of the symptoms. Also, it can be expected or diagnosed during the abdominal examination. By ultrasound, it can be ensured that the case is twin or multiple pregnancy. Now we will go through a study case. This is the source of my study case, obstetrics and gynecology competency-based companion. There is a patient present to the clinic after undergoing ART. ART means assisted reproductive techniques. She was told that she was pregnant. She was pregnant with a twin gestation at 10 weeks gestation. So her infertility center, after making the ART, with a follow-up, they told her that she was pregnant at 10 weeks. The patient came to the clinic to you, and she is very curious about two things. She is asking, is her pregnancy identical or monozygotic or dizygotic? This is another terminology. We just finished speaking about dichorionic and monochorionic, diamniotic in both conditions. Here, another term, monozygotic or dizygotic. Also, she has some concern about the antenatal care and delivery. You can look here. She is asking one very basic question. Uh, these two embryos, these two fetuses are dizygotic means what? Monozygotic means what? From number one, the infertility center during the injection of the embryo of the ART, usually if they injected two embryos and now the condition has twin, so by default these two embryos are different from each other, so it is dizygotic because two embryos has been injected. But in some conditions, in rare conditions, one of these can divide. It is very difficult. If fertilized ovum can divide for the monozygotic condition, yes, it can divide. But dizygotic is very common, as we will see in the next slide. The monozygotic usually represent about 10%. So 10% of the cases is usually monozygotic. 90% of the cases are usually dizygotic. So if they are dizygotic means what? Each zygote is an ovum with a sperm. So if this is dizygotic, so two ova and two sperm. This means what? These twin pregnancy are two different ova and two different sperm. So they are dizygotic or fraternal, different from each other. While in the monozygotic, it is one zygote, one ovum with one sperm, and after some time, due to some reason, usually genetic mutations or some genetic factors, this single zygote will divide. It may divide completely into two identical embryos or identical zygotes, or it may divide incompletely. If the division of monozygote or the single zygote into two zygotes in the first 3 days, there were a resultant two completely separated zygotes. So again, it is dizygotic. Similar to dizygotic of fraternal? No. These are dizygotic X1 and X2, but they are originating from one zygote. So they are identical. They have the same cells, they have the same sex, and they are identical. While this separation, if it occurs later on, it can lead to just incomplete separation of the chorion with complete separation of the amnion and fetuses. So you will have this condition with single chorion and two amnion and two fetuses. So it will be monochorionic diamniotic. Monochorionic diamniotic. In this condition, in rare conditions here, we can find just single placenta and single amniotic cavity, and inside there is one embryo or one fetus later on and second fetus. So in this condition, it is monochorionic monoamniotic, which is very rare. If we look at this classification, we can find again, to make it short, Dizygotic represent 90% of the cases. Monozygotic represent 10% of the cases. Out of these 10% of the cases, 20% of them are dichorionic. So totally, the dichorionic may be originating from dizygotic twins or it may be monozygotic twins. So dichorionic differ from dizygotic. Dizygotic, dichorionic. Monozygotic, dichorionic also. While the monochorionic, diamniotic, monochorionic, monoamniotic, both of them are variants from monozygotic. We will later on concentrate on this classification, but this is to answer the case. There is no conclusion at that stage unless we can find some extra indicators as we will discuss later on. Also, the case asks about her antenatal care and delivery. Regarding the antenatal care, what she can do or what we can do for her. This case needs proper follow-up. This proper follow-up for antenatal care, it can be every 4 weeks or every 2 weeks. According to what? If it is dichorionic, so follow up every 4 weeks. If it is monochorionic, follow up every 2 weeks. From where we can know dichorionic and monochorionic? We just finished since a while the issue of ultrasound, diagnosis of different chorions, and the lambda sign and the inverted T sign. You can revert to these slides. So regular examination, okay, vital examination, vital signs follow up. Why? Why vital signs is needed in this case? Because we need to follow up for the blood pressure, for the urine, for the respiratory rate, because all of these need to be followed to fearing of occurrence of any complications in this case. Second point is abdominal examination. Again, from the slides of the signs in twins, abdominal examination to measure the abdominal girth more than 100 centimeter. Second is the symphysis fundal length and the longitudinal, the presence of abdominal wall edema. All of these are suggestive and they can be present in any case of abdominal distension, twins or other than twins. If there is a mass, if there is polyhydramnios or anything like this. But the presence of two heads, diagnostic. The presence of more than 2 pools, 3 pools or more is diagnostic. This is by palpation. Doing the abdominal grafts, Leopold maneuver, it is very important here and it can be later on ensured by ultrasound to diagnose the presentation of different fetuses. When the case is approaching the time of delivery, we need to specify whether the first fetus is cephalic or presented by vertex or presented by breech or transverse, because there are different percentage of each type, vertex, breech, and so on. And the most important is to decide later on the mode of delivery or the planned mode of delivery according to these different presentations. Also, in the antenatal care, we need to make some investigations, whether these investigations are done for screening for the medical disorder. We need to follow up regularly the issue of anemia. We need to follow up and screen regularly the issue of diabetes mellitus, because gestational diabetes and the anemia are very common in these cases. Also, investigation to ensure the condition of the fetuses. Ultrasound is very essential. Doppler study is very essential for the follow-up, whether in normally growing twins or abnormally growing twins in some conditions, as we will discuss later on. So in the antenatal care for this woman, to tell her that if we find the ultrasound dichorionic, we will make follow-up every 4 weeks. Monochorionic, we will make every 2 weeks. It is similar to the items of routine antenatal care, but we will concentrate on certain physical finding in twins. We will concentrate on certain investigation in cases of twins. The case asks also about the mode of delivery. Yes, here during the antenatal care. Yes. Okay. Regarding the delivery, the first and the most important point, this one, number one, the proper place of delivery. Twin pregnancy or multiple pregnancy is a very high risk case. So delivery should be done in a place planned or prepared for management of high risk condition for the mother and for the baby. Number two, decide some cases of twin pregnancy can be allowed for vaginal delivery if vertex and they are of reasonable size and the first baby is engaged and there is no contraindication for vaginal delivery. So vertex vaginal delivery. Vertex breach or vertex transverse, we can give a trial. And in this trial, without prolongation of delivery, after delivery of the first baby, which is presented by vertex, we can see here that the breech baby or the transverse baby, after delivery of the first twin, they can be extracted whether breech or the transverse. We can make delivery of second twin by internal pudendal version. If the first is breech with anything, or if the first is transverse with anything, so cesarean section is indicated. So the route of the delivery is either vaginal, trial, or cesarean section. If we give a trial, if the first baby is vertex and second is breech or transverse, and we give a trial, what we can do for second twin? Number one, artificial rupture of membrane after ensuring of the presentation. If it was cephalic, it can be delivered with some oxytocin, or if it is breech, we can make it breech extraction, or if it is transverse, we can make internal pudendal version, and so on. Is cesarean section can eligible for second twin? Yes, in some cases, if there is indication for cesarean section. But for second twin itself, if the liquor, if the membrane ruptured and there is no amniotic fluid, so drained amniotic fluid and it was transverse, it will be impacted. We cannot make any version or any maneuver. If during delivery fetal distress occurred, if during delivery it was failed extraction or failed internal pudendal version, and so on. We have to be very cautious from occurrence of postpartum hemorrhage and some issues in the puerperium. But most important issue, the woman will deliver in a proper place which is prepared for this maneuver. Number two, the route of delivery can be vaginal, cesarean, or a trial. Number three, care for second twin, and then care for the woman in baby. We can just have here a chance for breaking before the second case. After this break, we can go to the second case. Case 2A. We have a case, 37-year-old, gravida 2.1. She came at 18 weeks of gestation. She has previously delivered 8 years ago, normal vaginal delivery. She is now pregnant, and this pregnancy, this is very important point. This pregnancy was achieved by IVF or in vitro fertilization or one of the techniques of assisted reproductive techniques. The woman has nausea and vomit. This is from the history. Again, to apply what we have studied. Are there any risk factor for occurrence of twins? Yes. The woman has history of in vitro fertilization. And as we said before, this in vitro fertilization is a great risk for twin pregnancy or multiple pregnancy. Again, in the history, are there anything in the history going with the symptoms? Yes, excessive vomiting and nausea. But this is not diagnostic for twin. But in cases of twin, it is present. So, by examination, the blood pressure was 145 over 95. Is this blood pressure normal? We can think a normal blood pressure up to 140 over 90. So there is mild elevation, 5, 5 millimeter mercury, increased in the systolic and in the diastolic. So there is very mild increased blood pressure, very mild hypertension. Is this hypertension or mild hypertension has has relation to the twin pregnancy? Yes. With twin pregnancy, with multiple pregnancy, there is tendency for pregnancy-induced hypertension, or sometimes full picture of preeclampsia. So this is association. The fundus is palpable at the level of umbilicus. What is the level of umbilicus as regarding the fundal level? The fundal level is felt at the level of umbilicus, usually at 20-22 weeks. So it is more than the period of amenorrhea. Again, for differential diagnosis, it can be found in some conditions of intrauterine lesions, twins, okay, polyhydramnios, okay, hydatidiform or vesicular mole, okay. So if we are talking about twins, about history of IVF, about excessive vomiting, about mild hypertension, about fundal level more than period of amenorrhea, so we have here 4 points are with twin pregnancy. So what is next? What we can do for her after examination and history taking? What we can do for her? First of all, by review of the file. The patient file showed that in the first trimester ultrasound, it was mentioned that there is a twin gestation. Okay, so it is twin pregnancy. So these symptoms, nausea and vomiting, is due to twin pregnancy. And this twin pregnancy is due to IVF or assisted reproductive techniques. This mild hypertension is due to the twin gestation. The fundal level is more than the period of amenorrhea is due to twin gestation. With positive lambda sign. So the ultrasound mentioned that there is positive lambda sign. Positive lambda sign, as we see, as we revised before in the signs of ultrasound, the presence of lambda sign means what? Means double placenta, means dichorionic pregnancy. Dichorionic pregnancy, yes, dichorionic pregnancy. Can we speak about this pregnancy dizygotic or monozygotic? Theoretically, so long as there is IVF, so the injected embryos inside the uterus, and so long as it is twin and it is dichorionic, so theoretically it is dizygotic, but there is no ensuring about this point now. But now we have twin pregnancy by ultrasound with positive lambda sign. Look at this ultrasound. Where is the lambda sign? This, the first on the middle, or the second photo on the left. Where is the lambda sign? If we look here, so we have two photos. We have ultrasound, said that it is twin, yes, twin, positive lambda sign, this or this. Okay. Lambda sign on inverted Y sign, look here, this is the lambda sign. But here, very thin membrane and inverted T sign. So usually in the inverted lambda sign, which is dichorionic, while the inverted T sign, usually it is the monochorionic. So this is dichorionic pregnancy or dichorionic twin pregnancy, dichorionic diamniotic. This is monochorionic diamniotic. In our case, there is positive lambda sign, so it is dichorionic. Later on, if the case was submitted to make a CTG during delivery, so the case came later on, and we found two traces of fetal heart rate. This is number 1, R, and L. Look here, there is no contraction, so it can be very early in labor, or can be non-stress test, but this is wrong. So long as there is the second trace of the contraction probe, so it is a CTG. So these double trace, so we are sure now that the condition is twin. Later on, normally developing here, normally developing fetuses, the heart rate 145, 154, normal fetal heart rate, no complication. So what is the most likely diagnosis? Definite twin, definite dichorionic, but we can most probably or theoretically it is dizygotic. Again, what is the likely antenatal care? It has been discussed before. What are the likely complications? Many complications can originate, but it is very theoretical and it is not our topic today. We are just speaking about how to diagnose, how to plan the management for any case. This is the case of 2A. If we look again, the same case with some variation, the same case, we make some variation in the scenario. The same case here, yes, 18 weeks, she has nausea and vomiting. Okay, where is the IVF? There is no. It was not mentioned here that there is IVF. So until now, this is a normal scenario with nausea and vomiting. So it can be pregnancy with hyperemesis. Okay. The same scenario of blood pressure, the same scenario of fundal level. Again, the same scenario. What can be done? Again, looking at the file. Ultrasound showed twin pregnancy with no documented other signs, and this is the dilemma. So our case is a twin without IVF. This twin was associated with mild increase in blood pressure. It was associated with fundal level more than the period of amenorrhea. Ultrasound in first trimester mentioned that it is a twin. Usually the ultrasound in first trimester should be more detailed and should mention if it is dichorionic or monochorionic. So we have the two pictures. Which of them is our case? We cannot say. We cannot tell. So our case can be dichorionic or monochorionic. We cannot tell whether of which. So is this similar to the first case? No. In the first case, it was mentioned in the first trimester ultrasound the positive lambda sign. So it was definitely dichorionic and so on. But in this case, we cannot tell whether it is dichorionic or monochorionic. Is this have some prognostic findings? we can see. Is this important in the management of the case? Also, we can see. So again, what is the likely diagnosis? Either monozygotic or dizygotic, as we described before. Our case is a twin pregnancy. There is no evidence that this twin pregnancy is monozygotic or dizygotic. There is no evidence if it is dichorionic or monochorionic until now. So this is a different classification of pregnancy, as we mentioned before. In the first case, it was definitely dichorionic in this category, whether dichorionic fraternal or dichorionic identical. But in this case, in the second case or case 2b, there is no evidence whether it is dichorionic or monochorionic. Later on, in the first case or in case 2a, later when she came later on and the CTG was normal for two fetuses. This case came later on at 27 weeks gestation. This is twin A and this is twin B. The estimated fetal weight for both of fetuses is presented. The amniotic fluid regarding the vertical bucket also was presented. For twin A, the fetal weight is 700 grams, with the vertical bucket is about 2 centimeters. While for twin B, it is 2000 grams, 2 kilograms, the weight, and the vertical bucket is 12 centimeters. What is this? Is this normal? Is the difference in fetal weight is normal? Is the difference in amniotic fluid is normal? So our question, describe this condition. What? There is definite discordant growth. There is definite difference in the growth between the two fetuses. Is this growth is significant? Yes, because there is an accepted level of difference. If there is 20% difference between these two fetuses, it's okay. The difference here is more than 60% between these two fetuses. So there is discordant growth. This means that twin A has markedly reduced growth. Twin B has excessive growth. Here there is oligohydramnios, and here is polyhydramnios. If we find the discordant growth with oligo-poly sequence, this is a very complicated case. This complicated case is due to vascular anastomosis between the two fetuses and the sharing of the placenta. What? Sharing of the placenta? Is this case of twin pregnancy with one placenta? So it allows sharing and vascular anastomosis? This is definite from this finding. One placenta means monochorionic. So this pregnancy was monochorionic pregnancy. Again, we can go to the previous slide and look here. This pregnancy was monochorionic. Monochorionic diamniotic. This monochorionic diamniotic means that single placenta, double amniotic cavities. Okay, what is the difference? Look here at this sketch. If we have one source of water pipe and we have here one and the second, the first one is taking his very good amount of water, and this one is taking very low amount of water or no water at all. So there is oligo and there is poly, there is IUGR here, there is macrosomia here, similar to what happened in the twin to twin transfusion syndrome. This leads to discordant growth. The first twin is 700 gram, the second twin is 2000 gram. There is marked increased amniotic fluid or water. There is minimal water here, oligohydramnios, polyhydramnios, and this is a condition of monochorionic diamniotic pregnancy. What is the sequelae? Monochorionic diamniotic pregnancy usually is associated with twin transfusion syndrome, but with variable percentage. Not all the cases of twin to twin transfusion syndrome are dangerous. If there is minimal transfusion, there will be minimal variability in the growth of the fetuses, but it is not similar to this. If the growth is definitely affected in one of the fetuses with IUGR and the other with macrosomia, oligohydramnios, polyhydramnios, this is very dangerous situation. Can we detect this condition from the start? Yes. Theoretically, yes. If we know from the start that the condition is monochorionic, okay, this is very high risk case, so the follow-up will be different, regular follow-up, ultrasound, and so on. But if we don't know that it was monochorionic, like our case, if the case neglect her antenatal care, if during antenatal care the fetal weight and amniotic fluid was not followed up thoroughly during ultrasound examination, this condition can occur. So it can be detected theoretically, yes. So the likely diagnosis, it is a monozygotic. It is monozygotic or dizygotic. Monozygotic. It cannot be dizygotic at all because it is monochorionic. Monochorionic is monozygotic. What about the sex of these babies or the gender of these babies? 100% that they will be the same sex because they are monozygotic. So monozygotic, monochorionic, diamniotic pregnancy, the antenatal care and complication are slightly more than the diamniotic, dichorionic diamniotic, but here we need to stress that antenatal care must be done every 2 weeks, searching for possible complication, maternal and fetal. It will be discussed later. Again, for this case, look at the bathtub here, the water here and water here. If we want to find a solution for the issue of these people using water for bathing here, what we can do? Either we make extra pipe for the second one with extra water supply, which is difficult, or we can make some valves here to control this. So the issue is to control the connection between these, or to find extra connection with the second one. Again, to our feet. What is the next step if you find the case like this, and why? Is the next step is to do chorionic villus sampling, or to give some drugs to increase the blood supply, or laser vessel ablation, or to repeat ultrasound in 3 weeks. Chorionic villus sampling at 27 weeks, its date is out. So it is first trimester until, so it is finished. Repeat ultrasound in 3 weeks. So after 3 weeks, what can we expect in this case? There is marked discordant growth, marked oligohydramnios, definite twin to twin transfusion syndrome, with pathological manifestation on the fetus. So if we wait for 3 weeks, it's very dangerous. The fetus may die. So this point also is not right. So here, so this point is not right. This point is not right. Drugs to increase the blood supply. This is one of the conservative management where we can give drugs to increase blood supply for theoretical reasons. There is nothing definite until now that can increase the amniotic fluid, but all the trials can be given. But for IUGR, they can be tried, but there is no definite line until now. For early cases, it can be tried, but for advanced case like this, what is the laser vessel ablation? Okay, we need a definite management for such case. If we look again to that scenario, we need to block between them. We need to block the tube between them to keep this fetus live, to keep his growth, and this will grow, but this is one of the conditions which is very dangerous. We can speak later on about 2020 transfusion syndrome, but again, this is one of the solutions is to ligate or obstruct or occlude these vessels between these two fetuses, which is laser photoablation or laser vessel ablation in this scenario. So this is the right answer and why. Another case, 28 years old gravida 1 patient diagnosed to have a twin pregnancy. Ultrasound showed a very thin membrane between the two fetuses. Now we are very well oriented about this photo. Look at this photo again. There is very thin membrane between two fetuses. This very thin membrane means what? Yes, means two amnion, okay? What about the chorion? So diamniotic, it's okay. The chorion is single. This very thin membrane means single chorion. So monochorionic diamniotic. And this single membrane with the inverted T sign. The inverted T sign means that monochorionic diamniotic. Monochorionic diamniotic. Okay? So what is the most likely finding and why? Look at these four options. We can discuss one by one. The first option says that there is one fetus male and one female. Is this option legible or it can be chosen? What is the clue to say about gender of the baby? If it was mentioned that it is monozygotic, we can say this. Wrong. Because if there is thin membrane and one chorion, this means monochorionic, diamniotic, and the monochorionic diamniotic is variant of monozygotic twin. Monozygotic twin means the same sex. If it was said that one fetus male and one fetus female, it is wrong. So A is wrong. And why we just described. Number D. There are two separate placentae or placentas. Again, this sign is single placenta. Inverted T sign is a single placenta. Monochorionic diamniotic. So again, it is wrong. This is dizygotic gestation or monozygotic gestation. Dizygotic gestation never give single placenta. Dizygotic means double placenta. So it is wrong. So this is a monozygotic gestation, yes. Monozygotic gestation, it can be dividing into di and di or dichorionic diamniotic, or it can be monochorionic diamniotic over monochorionic monoamniotic or conjoined twin. So this is one variant of monozygotic gestation or monozygotic twin. If you look here, to wrap up our topic, very important to speak about zygosity, single zygote or double zygote. Double zygote, so it is dizygotic 100%, or single zygote, here is one and here is two. So what about chorionicity? About the placenta? Placenta may be two, maybe one. If we are double zygotes, 100% they are double placenta or double chorionic. But if they are single zygote, it can be one chorion, monochorionic, or it can divide into two, it can be two chorionic. Dichorionic is diamniotic. This dichorionic is diamniotic. Okay. What about this monochorionic? This monochorionic, it can be diamniotic. It can be monoamniotic. It can be monoamniotic with adhesion or plus conjoined. So zygosity, chorionicity, and amnionicity. Consider that any case of twin is liable to multiple complications during pregnancy, multiple complications during labor, multiple fetal and perinatal risk. All the high risk pregnancy complications are present in multiple pregnancy or in twin pregnancy, except post maturity or post date. During labor, lot of complications like prolonged labor, obstructed labor, dysfunctional labor, all the complications of malpresentation, premature rupture of membrane, cord prolapse, instrumental delivery in second twin, maneuvers, intrauterine maneuvers, cesarean section, postpartum hemorrhage, all of these complications can develop. Multiple fetal complications starting from abortion, malformation, intrauterine growth retardation, preterm with its complication, IUGR, twin-to-twin transfusion syndrome, all of these fetal complications. So in any case of twin, after consideration of diagnosis and therapeutic points, we have to be very cautious, very well about the complication during pregnancy, complication during labor, and complication of the fetus and the newborn. So delivery must be in a very well prepared place with a very experienced physician to deal with these conditions. هنشوف ايس بريكنج كليب تاني.
What do you have in there? You were telling me? You have marshmallows? Where are they?
This is the twin pregnancy. No, another twin case, not the first twin. These two babies. One is very intelligent and active. The other is very energetic and defiant. Okay. They are very well cooperating. Look at the first one, he's guiding him about the side of the street. Okay. And now
What are you going to do with those marshmallows?
زي ما ابتدينا، احنا عندنا النهارده ثلاث حاجات او ثلاث اهداف للراوند. Number one, diagnosis from the history, risk factor, symptoms, and examination and investigation. After that, study some clinical cases and concluding with the scheme for the focused history. Focused history in a case of twin. Usually you have 5 minutes in the OSCE. So what we can do? What's your age, from where you are present, and the residents can indirectly tell about the race. And also we know that the age is very important about the risk factor of occurrence of twin pregnancy. Last trimester period and calculation of expected date of delivery, and the multiparity also is very important point for a risk factor of twin pregnancy. We need to ask about the current pregnancy finding, what has been told to her, what the diagnosis that has been given to her, what is the ultrasound finds, what are the symptoms that she has, like hyperemesis gravidarum, what is the nutritional status, is she receiving iron, is she receiving folic acid, is she receiving vitamins or special diet, and so on. The past history, we need to ask about infertility or ART or previous twin pregnancy, twins, abortion, malformation, and so on. All of these conditions need to be asked during the scenario. Again, we need to ask about the family history and the mother trait or family history of twin pregnancy, about the race of the family and the race of because we have the race is very important in risk factor in occurrence of twin. And lastly, about the complaint and the association, we need to ask about the problem of the case. What is the primary complaint for her? Is she was she admitted for just to do antenatal care, or was she admitted for some medical issues? And we need to ask about, especially about hypertension, diabetes, respiratory problem, cardiac problem, if there is any vascular problem in the body, or if there is any obstetric condition like preterm labor, premature rupture of membrane, polyhydramnios, possibility of admission to be prepared for non-stress test or CTG, or possibility of being admitted to be prepared for delivery, whether vaginal or cesarean section. After finishing these items, we can conclude that from the risk factors in the history, from the symptoms, from the medical condition, and from this complaint, primary complaint or other complaints, we can conclude that the case is twin pregnancy or multiple pregnancy with this 1, 2, 3 symptom, or with this 1, 2, 3 complication, and she is admitted for 1, 2, 3, or what is the primary indication for admission. After that, we just finished in 5 minutes or less than 5 minutes. We can we can expect that the examiner will ask us about some factors here, some risk factors and its relation, or some finding and its relation to the case. What is the ideal antenatal care for such case? What are the complications which can occur whether during pregnancy, during labor, or during the neonatal period or puerperial and neonatal period? Uh, by this, we finished our round, and so we can conclude that. Thank you very much. If you need anything, you can communicate with me through the WhatsApp or through the email. And waiting for your concerns, waiting for your questions, and waiting for your discussion. Thank you.